So here we talk about prognosis studies, what's the motivating question clinically, and what is the driving factors for the hierarchy, which would be study designs. So first we talk about the motivating question. And so here we see an ankle fracture, and the ankle fracture on the left is minor compared to the one on the right. And so we wonder is if this, just the fact that one's more severe than the other, does that help us anticipate or look into the future and determine who might have a worse outcome than another person? And in the study that we're going to review in a minute, that way that's dealt with is something called severity, which is a common prognostic factor. And it's looked at by looking at people who had surgery, because we know that the person with the comminuted fracture here to the right would have had to have stabilization, where the fracture to the left may or may not have. And then we can also look at other factors like age and gender. And so this systematic review included both Inception and retrospective cohort studies, which we'll learn about in a minute, but they're a compilation of 31 studies, which is why it's going to be ranked as a higher level study, because it basically is including all of these different sources of data that are fairly good. Now, it looked at two things. One, time, so we have 0 to 24 months or 2 years, where 0 is the point they get out of a cast or being weight bearing, and then the x-axis is physical function, and they looked, two scales were used to collect that, the lower extremity functional scale and the Olerud-Molander scale. And so where 100 is normal function and 0 is no function. And immediately, just the descriptive data helps us, because it's like, where do we start with patients and what kind of evaluation or assessment procedures do we need? And we can note that a 20 or 80% disability or loss of physical function means that our assessment procedures are probably going to be low level, range of motion, strength, things like that. But this also tells us that they're going to improve quite rapidly, where at 3 months, they've essentially achieved a large percentage of their recovery. And then from 3 to 6 months, it'll be fairly low. And then from 6 to 24 months, very minimal amounts of recovery. So it helps us kind of relate to our patients and understand when the critical times are in terms of increasing abilities. The other thing it does is it starts to focus in on what the variability here, this adjustment, how to make adjustments for important individual characteristics like age and gender. And this came out in the articles that basically there's a minor adjustment based on whether they have surgery or not. There's a bigger 10-point adjustment for age, and then also an expectation that males will do worse than females overall. So this kind of helps us in terms of dealing with patients and their expectations. Now, another type of application of prognosis studies, or a question we might have, is, does it help us decide or not whether we should follow through with certain procedures? And in this particular case, we're looking at patient reported outcomes, or the patient's self-ranking of their abilities relative to physical function. And rather than trauma, like we were looking at with fractures, we're going to look at an elective orthopedic procedure. So foot and ankle surgery, where there's a whole variety of foot and ankle surgeries represented, but should preoperative functional ability influence our decision-making relative to how a patient's going to come out? And so we'll use their postoperative outcome for this. And so here we plotted essentially their preoperative score on the x-axis, and their postoperative change is from their preoperative score is plotted on the y-axis, and the follow-up increment is 7 months. And so essentially we can see that the 50 here is the average of the U.S. population, and better function is to the right and worse function is to the left. So we're a 40 and a 30, this would be 1 standard deviation, or 10 points lower. 30 would be 2 standard deviations, and the lower at preoperative visit. We can see that there's more dots below 50 than above. So in general, people that are considering elective orthopedic surgery, we'd expect them to be lower in terms of function, and they are. That's why they're considering the surgeries. Now, on the y-axis, we see here is that improvement in function is above the line, and worse function is below. And we can see there's a clear relationship where patients who started off worse actually do better, and patients that start off having higher function do worse post-surgically. And there's our overall amount of improvement. But we also notice that it's about 50-50, so it would be more optimal for us if we could eliminate some of the patients who weren't improving and have a better outcome from the procedure if we just chose patients who were more likely to respond. And that would look something like this. So we could advise the patients here with the sad face. So if we had a cutoff of 42, so a preoperative cutoff of 42, we could advise them that, you know, the odds of them improving from the surgery are less than other people, and that they may consider alternative treatments or waiting some amount of time before undergoing the procedure to see if they could experience recovery some other way. So what did we learn? So we learned that two things critical for prognosis studies is what our expectations are in terms of recovery, what the patient's expectations are in terms of recovery, exactly how much adjustment we should be making in terms of some important factor that we think is relevant, like age or gender, and what we don't want to overestimate the effect of age, or we would undertreat our patients. And so this kind of helps us ask questions like that. And then it also helps check us in terms of our use of our expectations of what our treatments can actually do with people, where in this particular case, patients that were categorized as higher functioning didn't recover nearly as well as patients that were lower functioning. And so the expectations are is the procedures don't work as well for patients that are higher functioning. So those are the types of questions we could ask with prognosis studies. And now the second question is, how do we trust or give weight to different prognosis types of studies? And so for that, we have a hierarchy of evidence which has been provided to help us when we're trying to sort out what studies mean. What their design is has a lot to do with whether we should trust them or think of them as valid or not. And so essentially what the hierarchy is telling us to do is kind of take studies and rank them from 1 to 5, where 1 is high and 5 is low, and then call these different, pay attention to certain study features that make them more trustworthy or not. So we'll focus on the 1B and 2B categories here, and in the 1B category, both are considered high. We can see these words for 1B, Inception, Cohort, and for 2B, we see Retrospective Cohort, and then a follow-up of patients in RCT. Then we're going to contrast that with low-level studies, 2C, which is outcomes research, and then case series. So let's start with the idea of an Inception cohort study, level 1B, and the key word here is Inception, where the patients enter the study at a common point in time, or which is usually the baseline or start of the disease. And the other key thing is about the sample. If we want to understand the influence of prognostic factors, we have to have a heterogeneous sample. So that means a sample that includes people that are both positive and negative on the prognostic factor. So if the prognostic factor we're interested in is age, we need people who are both young and old. If we only have people who are young, then age will appear to be not a prognostic factor because we have nobody who's old, so we can't evaluate its influence or the influence of age. So we need heterogeneity on the prognostic factors. So in this case, both young and old people, or if we had severity, we need both people who have severe injuries and then people with non-severe injuries. So this is a good example. This is a study published in the Journal of Bone and Joint Surgery in 2012, where they included people prospectively. They followed them starting at less than 72 hours after they had their injury, so they had surgery for a hip fracture, and then they included all comers. So by including all consecutive patients, that increased the heterogeneity of the sample and made a representative sample of people that would have the various prognostic factors. They tested their timed up and go test at less than 4 days and 3 weeks, and then followed them for 12 months to determine if they needed an assisted device at that 12-month point. They also looked at just a description of their recovery, and we can see here the influence of the inception point. So by looking at this blue line, which in this case is the lower extremity measures, this is their self-report of their functional abilities before their fracture. So they were about 85 out of 100. Then after their fracture, they plateau an improvement at about 1 year at about 70 out of 100. And so we can see is the importance of the inception point. So if there were, this particular study started all of the data within 4 days. And so the increment from 4 days to 6 months, or to 1 year, to 1 year, is represented by this arrow and is approximately 20 minus 75, so 55 points. Now, if we had instead had a width and inception point that varied between the start of the surgery and 3 weeks, the increment of improvement would have been much less. So it's represented by this arrow here. So it would be something like 35, it would be like 45 points. And so the point is the larger the window or the wider the inception point, then there's going to be different levels of recovery for each person, and that would be attributed to different prognostic factors. So if we want a high quality study, what we're looking for is a common inception point where everybody has the same chance of experiencing this large increment in change, and that the changes don't vary because one person started at 3 weeks and another person started at 4. Okay, so we want that common inception point. So then a retrospective or level 2B study is we're usually mining a database is the most common way this is going to be performed, and it's a very common way of approaching prognosis. And what we need to do then is look back in time and try to find a common inception point. And so a preoperative clinic visit is a great inception point for looking at surgical data. It's more difficult to get inception points, for example, for ankle fractures, where we're trying to find the visit where the person started weight bearing. It's not as defined in the medical record, so it's more difficult to determine when that was. And so that might have to do with the effectiveness or a problem with why it's a level 2B study. How do we find that baseline point? The other issue is if it's retrospective data, we don't have the equal chance of catching everybody at the follow-up. And you'll see that in the next example where the follow-up point is usually incomplete. So that's why it's a lower level of evidence. So here's a good example. So in this case, we were able to capture the preoperative visits, so that's not as much as a problem. but we weren't able to get a full spectrum at follow-up. And here's an example. This is the patient flow sheet, which most studies nowadays have patient flow sheets. And you can see that there's the potential visits. We have 8,000 potential visits, reduced to 4,000 because of different criteria, and we end up with only 61 operative patients when clearly there were hundreds of operative patients that year. And so the proportion of patients that we actually capture is much lower than the number that got the procedure. So the risk is, in terms of trustworthiness, that this sample of 61 patients has some kind of characteristics that make them highly selective, and that therefore may give results that are slightly off. Okay, and in essence, what's more probable is that these patients weren't doing as well as some that didn't come back, and therefore might downwardly grade the outcomes. And so then another type of 2B study was a follow-up of patients in a randomized controlled trial. And the main reason for this is that the inception points are not usually determined by the start of the disease, but most of the time people can come into the studies from different inception points, and that the groups are fairly homogeneous, and essentially they don't represent all comers, because an RCT by definition requires people to come in that only meet certain inclusion-exclusion criteria. And that contrasts with a cohort study where we want all comers, or all people with the disease, and just that they started at a common inception point. And so the heterogeneity in the study sample or the disease state won't be represented in an RCT. And so this is why the result may be slightly affected by that. So its trustworthiness is slightly less than an inception cohort study. So the next level down is a big jump down, and we just have basically outcome studies. So we're just looking at describing a pre-test and potentially a post-test of how somebody comes out over time. And a case series is another kind of example of that. And so a case series is you're just looking at a pre-test and a post-test. And we'll talk more about the differences between these two throughout the class. A good example of a purely outcome-based type of report would be data that is collected from the collaborative MD-PT model that was being instituted at the Providence Medical Center in Newburgh. And we looked at musculoskeletal patients and called back those patients at 2 weeks. And there were about 400 patients seen over that time period, and so we collected about 20% of the sample. Now, but the data we have is purely just descriptive or outcome based, and so basically we're just describing their result in the patient acceptable symptom state, and noting that only about half the patients would be considered pass yes, or have acceptable symptoms at an average of 14 or plus or minus 8 days callback. But notice there's no prognostic factors identified, and there's no solid assumption of what they were at baseline. So we've reviewed the motivations for prognostic studies and the hierarchy of evidence used for prognostic studies. We've noticed that one of the key things is to take away is understand an inception cohort study and how that differs from a retrospective cohort study, and then contrasting that with outcome studies to understand how to apply the hierarchy of evidence in practice.